Okay. So the most common example that we discuss when we're talking about RH factor is going to be the pregnant mom. But it can happen anytime when there's going to be a mixing of blood. Right? But it's always going to be an RH negative person. Okay, so initially, an RH negative person, because they have, all right, the antigen, okay, or the antigen D, all right, on the surface of the red blood cells. Okay, but they won't have any antibodies. But I say, flip that. RH positive person will have the antigen on the surface of the red blood cells, but they won't have the antibodies. Okay, the RH negative person has no antigen on the red blood cells. Okay, but all right, if they've never been exposed, all right, here, I'll show you the picture. There we go. Pictures always help. Okay. Yeah. Okay. So RH positive person has the surface antigen, but no antibodies. Okay. The RH negative person, all right, doesn't have the surface antigen and will not have the antibodies until they're exposed, okay, to an RH positive blood type. Okay. Keep that in mind. So the example that we're going to use, all right, is going to be pregnancy. Okay. So we got mom, okay, she's RH negative, okay, and so she has her first pregnancy, she has an RH positive baby, okay. So now she has been exposed to the RH positive antigen from baby's blood. So now mom has developed the anti-D antibodies. So for the next child, okay, if that next child, all right, is going to be RH positive, okay, there can be, all right, a crossing over, because antibodies are really small. Placenta can block out a lot of stuff, okay? That blood system blocks out a lot of things, but big things. But really small things, not so much. Antibodies count as those small things, okay? So what will happen is, all right, now that mom has the antibodies, okay, for, all right, the RH antigen or the D antigen, okay, if the next baby is RH positive, then we can get agglutination, okay, that clumping of red blood cells, which is bad. Eventually that can lead to, over a long period of time, all right, because eventually those red blood cells will break down, call that hemolysis. And that breaking down of those red blood cells can damage tissues and organs, okay? It's just like glass shards flowing through your body, sort of. Not the same, but something similar, right? It doesn't feel good. So it causes the destruction of these red blood cells. So that's why, okay, we'll see, all right, if the situation occurs during pregnancy, we get this hemolytic disease of the newborn here because the red blood cells break down. So our red blood cell count is going to be low. We're going to have a low oxygen carrying capacity. Okay, so they'll be anemic. They have hyperbilirubinemia. So they'll have high amounts of bilirubin in their blood. And as we know, bilirubin is one of the intermediates of the breakdown of hemoglobin, okay, which is that oxygen carrying protein molecule in our red blood cells. So we'll see high levels of that, all right. That will cause the heart for the infant to have to work harder to pump blood that is low oxygenated blood. And so eventually that can lead to heart failure and then death. Okay, so it's not good. So what do we do to avoid that? Well, guess what? We're going to give mom Rogam. Okay, something that's going to help to deal with those antibodies. Okay, because that's what the antibodies are. They're immunoglobulins. Okay. So that's for the RH factor, okay, or antigen D. Okay, enough about red blood cells. Let's get into the white blood cells. Okay, now we're going to get into more detail when we get to the immunology chapter. So we're just going to give a kind of an introduction into some of the players. Then we get to learn about how they handle, which will be really interesting because I'm sure that A lot of us have been hearing a lot about this with, you know, COVID and whatnot. And so usually more people take interest in that when it's something that's actually happening. Okay? So leukocytes are white blood cells. Okay? Their job is to defend our body from bad things. So those bad things, we refer to those as pathogens. Okay? Big difference between these cells and the red blood cells, we have yet to talk about the platelets, is that these cells do have a nucleus, okay? And they do have organelles. So if they have a nucleus, they have a control center, and they have organelles, that means they're going to make stuff. Depending on what cell that we're talking about, depends on what it's going to make. Okay, so it's going to be making all sorts of stuff, and we'll talk about that for their immune function, but it does not have hemoglobin. Hemoglobin is only present in our red blood cells. Our white blood cells do not carry oxygen around. That's not their job. Okay? So these cells have to fit into tiny nooks and crannies throughout the body. Okay? Believe it or not, a majority of these cells reside in the tissues, not in the circulation. Okay? A lot of people think that your white blood cells are going to be present in the majority of your circulation. It's in tissues. Okay? So here's what we're going to see. They have to move into these tight spots. So these cells need to be flexible. Modal means mobile, okay? So there's two terms that you need to understand when we're talking about our white blood cells. One is diapedesis, and that's the ability for these cells to squeeze between things. Namely, all right, the endothelium, which is the simple squamous epithelium that lines lymphatic vessels and it lines your blood vessels. It also lines the endocardium, okay, the lining of your heart, the inner chambers there. It's the same stuff. It's contiguous with the blood vessels there, okay? So for these cells to be able to squeeze through those blood vessels, we refer to that term as diapedesis. So when you hear me say that, you'll know. It's just trying to squeeze its way through, like if you're trying to put on a shirt that you haven't worn in a while or a tight pair of pants, same kind of thing. All right? So chemotaxis. You ever wonder how these cells know where to go? Like, how do they know? Something has to tell them where to go, because this is where the bad thing is occurring. Either it's tissue damage, or there's a virus, or there's a parasitic worm infection, or there's a bacterial infection. So it needs to know where to go. So the cells that are involved in that scenario are going to release chemicals. Okay? They're going to release the chemicals, and that will circulate around. Okay? Even if it kind of goes out into the immediate bloodstream near the area, well, there's white blood cells there, and they'll migrate to that area. Okay? So chemotaxis is the body's way of releasing chemicals, and then the white blood cells can know where to go. Okay? Like a dog on the scent, you know, when you're out hunting or whatever. You ever seen those movies when there's an escaped convict or prisoner running away, and they like, here, Barney, smell the shirt, and they chase after the guy? Similar, you know, chemicals, okay? So we're going to talk about the 5 different types of leukocytes, and we have those divided into 2 classes. It is real simple. All right, the names of the 2 classes. We've got our granulocytes and our agranulocytes. Okay? So these top 3 here are the granulocytes. We call that because they have, when we are looking at them on a light microscope, we can see that these cells have these little granules inside of them. So those are called granulocytes, and there's 3 of them: the neutrophil, the eosinophil, and then our basophil here. And then the other class is going to be the agranulocytes. Now they still have granules, you just can't see them very well under a light microscope. Okay? We have the lymphocyte, and then we got one of my favorites, the monocyte. Okay? So these are what we're going to see in our blood floating around. Okay? All right. So let's break it down here for you. Okay? So our 5 leukocytes have 2 classes. It has to do, all right, with those little dots that we see inside the secretory vesicles. Okay? So again, granulocytes, neutrophils, eosinophils, and basophils. So all the phils are going to be grouped under granulocytes. And then the other class is going to be the agranulocytes. Okay, again, they still have granules, they're just much smaller and difficult to see on the light microscope. Okay, so those are the lymphocytes and the monocytes. Give you a second to let that settle in as I take a drink of water. Good so far? Not too bad? Okay. All right, let's keep it simple. Two classes, granulocytes, agranulocytes. All the fills are with the granulocytes, all right? Then the lymphocytes and the monocytes, all right, are going to be in the agranulocytes. A meaning without, so no granules seen. All right, so the first type, the most abundant type of white blood cell, all right, are the neutrophils. These are very, very distinguishable because they have what we call a multi-lobe nucleus. I'm going to go back 2 slides here to take a quick pick. All right, and you can see if we zoom in here, okay, to our neutrophil, all right, we have all of these lobes here of the nucleus. Very, very outstanding. And they're drawing here, I think that's 4, close to 5. All right, the other ones do have oddly shaped nuclei too, but this one here is very, very distinguishable, okay? So that's going to be our neutrophils, okay? And so their job, all right, when they're in circulation, all right, is going to be to come out of circulation and move into the tissues. So that process we call diapedesis, okay? And what they do is when they enter into the tissues, does anyone remember what this term means? Yeah, it's eat, cell eating, all right? It's like the Pac-Man cell, just like that. It's going to gobble things up, okay? And that's what it does, okay? So it's going to find some sort of pathogen, all right? We refer to it as an infectious pathogen because it would be a virus, a parasite of some sort, all right? Bacteria, all right? So we'll see these, all right, in high numbers in somebody that has chronic bacterial infection. All right, neutrophils, I mean, when I was taking a clinical medicine class, they said just in general, when you're looking over a lab report, that if you saw elevated neutrophil count, that you're going to think bacterial infection. That's the first thing that you should be thinking of. I mean, there's other things. And if you see an elevated lymphocyte count, you want to think of a viral infection. But again, there's other things involved. But those were kind of like just the quick thoughts that you should be thinking when you look at a CBC with differential, and you see you have elevated neutrophil and elevated lymphocyte counts, okay? So again, we'll see very high counts of the neutrophils with a chronic bacterial infection involvement there. Okay, the second type are the eosinophils. Eosin is a red staining dye that they give when they're doing histology slide preparations, okay? And it has to do with the acidity, the pH, all right, of the structures inside here. Again, this has, again, a multi-lobe or bilobe nucleus here, except there's a little thin strand in between. I'm going to go back. I'm going to come right back. I promise. Whoops. And so you can see that right here on this slide, okay? You have one lobe here, another lobe here, and there's a tiny thin strand right in here. In our drawing, you can kind of see it right here, okay? That's for the eosinophil. Eosin is a red staining dye for our slide preparation here, okay? So again, these guys, all right, when you see eosinophils are elevated, you're going to be thinking of allergic reactions, okay? Allergens. You see people that have terrible allergies, so guess what? Down here in Greenville, South Carolina, people normally have, and you shouldn't be surprised to say normal. It's not normal to have an elevated eosinophil count. But if you do see it and they're complaining of, all right, allergies, don't be surprised. But also, they're going to come around and eat up those antigen-antibody complexes, which we'll talk about. Okay? An antigen is a protein, normally a foreign protein, and the antibody, we already talked about what happens. These antibodies glom onto the antigen and they kind of surround it. And then these cells go around to the cleanup crew. And they go around, they gobble up those antigen antibody complexes. Okay? But I think when I see elevated eosinophils on the CBC with DIP, I'm thinking, okay, this person probably is having an allergic reaction, but also, all right, don't rule out parasitic worm infection, especially if they've traveled outside the country. Okay, we'll go into more detail on this when we get to immunology. Okay, but that's what you do. You got to take, if you're taking a history on somebody, and you look and you're like, oh, elevated eosinophils, they just got back from Brazil. I'm thinking parasitic worm infection. Okay, probably drank something they shouldn't have. Okay, or ate something they shouldn't have. All right, that's eosinophils. The last granulocyte are the basophils. All right, these will have a blue-violet because, again, all right, the stain that we're going to be using on them, all right, is going to stain it blue because of the pH value. Okay, so this one again is a bilobed. All right, not a lot. Basophils, all right, we don't see a lot of those. Okay, they make up a very small percentage of the white blood cells, leukocytes. Okay, but important that you know, and I'll be really happy if you guys can answer this question for me. All right, these granules that are inside, all right, are histamine and heparin granules. So when you were taking 210 and you were learning about tissues, especially when you got to connective tissue, you learned about the components of connective tissue, cells and the extracellular matrix. And in some of these in some of these tissues, the cells, all right, we talked about different types of cells, and one cell in particular also had histamine and heparin inside of it. All right, does anybody happen to know the name of that cell? Does anyone at home remember the name of the cell? It releases histamine and heparin. That type of cell predominantly resides in tissue. These basophils will circulate through the blood. All right. Well, the name of the cell is called the mast cell, M-A-S-T, mast cell, and it has histamine and heparin. Okay, the histamine is nice because when it releases, this is why you get a runny nose. All right, when people take antihistamines, all right, they're taking Benadryl. Okay, it's because when there's a release of histamine, all right, it increases the diameter of your blood vessels, and if we're dealing with capillaries, it makes it leaky, which is good in the situation of the white blood cells having to leave the capillary, right? Because remember diapedesis? These white blood cells have to squeeze in between, and you've seen how tightly packed the lining of capillaries are. So if we blast a little histamine in there, it causes the cells to move apart and creates gaps. And then those white blood cells can squeeze in between, okay? Well, if you release too much histamine, it's called a histamine storm, and it can increase pain levels, but that's a different story. All right, so we have histamine release, increases blood vessel diameter, and capillary permeability, meaning makes it leaky. Leaky capillaries are good in this type of scenario when you need to get white blood cells from the circulation into the tissue. All right, and then of course heparin, we know that's a blood thinner. That's going to prevent the blood from clotting, because we might need to get more white blood cells to that area. We can't have it clotting. It's like putting a roadblock up to an accident, not letting the ambulance in. All right, we need to get that personnel to the scene of what's happening. All right, questions so far? Good? Okay. Granulocytes. Those are the three granulocytes, the fills. All right, now let's go see the sites, the agranulocytes, okay? So lymphocytes, when you look here, look at that, 20 to 40% of your white blood cells are going to be made up of lymphocytes. It's a pretty good amount, all right? So we're going to see these types of cells residing mainly in our lymphatic organs. Well, what are those? Lymph nodes, okay? Spleen is another lymphatic organ, okay? Some of our lymph vessels, all right? So these guys have a really big, I won't go back to that picture, but the nucleus takes up a considerable amount of space inside these cells, and it's a dark staining nucleus, okay? And so there's three types. All right, again, we'll talk more about these when we get to immunology. You have your T cells, all right? Then we have our B cells, and then our natural killer cells. All right, the T cells, we talk about when we say that they manage the immune response. All right, they're going to determine how much and how effective your immune response is going to be to certain pathogens, okay? So they'll help out there. B lymphocytes, these are huge because they convert into plasma cells. It's the plasma cells that make the antibodies. B lymphocytes do not. So if you're taking a test and it says on there that the B lymphocyte makes the antibody, no, it does not. The plasma cell, the B lymphocyte has to differentiate or turn into a plasma cell, then it can make the antibodies. Okay? And then finally, our last, the natural killer cells. I think that's just a really cool name. All right, these guys are going to go around and take care of misshapen or malformed tissues, all right, or any type of infected tissue. Okay, they play a pretty decent role in cancer, all right, just the general overall. And so this is just a little bit of a taste, all right, of what we're going to talk about when we get into the immune system. I just want you to be aware of some of the players here. All right, so that's the lymphocytes. And then our last type of agranulocyte, right, are the monocytes. Okay, they make up a pretty small percentage here of our blood leukocytes. All right, but these guys, okay, when they're in circulation, we call them a monocyte. But when they eventually get into the tissue, they transform, and they transform into these cells, macrophages. Macrophage is a big blobby looking cell, okay? It has lots of different functions, duties, all right? We'll talk some more about it, all right? But one of its big duties is to go around and eat things up, okay? This is the big cleanup crew. They do a lot. I love this cell. It's a cool cell, right? So it wanders around, all right, and it takes care of pathogens. So you could have a bacteria kind of hanging out there, a virus hanging out there. But if you damage tissue, these guys will come in, they'll migrate in there through chemotaxis, and they'll start, especially if you've damaged collagen fibers, right? They'll come in there and start chewing up the frayed ends of collagen. So then the fibroblasts can repair that, okay? So you'll see them, they're on site most times. Neutrophils and macrophages, or monocytes initially before they transform into a macrophage, before they migrate into the tissue. When you hurt yourself or cut yourself, those are going to be the cells that are first on the scene, okay? So neutrophils and macrophages will be there because they're going to start to clean up. Macrophages are going to go right to work. They're going to start destroying damaged tissue and eating that up, all right? And then they're going to also, if there's any pathogens there, they'll clean that up, while the neutrophils are going to be just killing and going after pathogens also, okay? More on that later. Okay, so a couple different terms that you need to understand when we're talking about white blood cells, all right? So when we order what we call a CBC with diff, the diff is when we're going to see all the different types of formed blood cells, all right, in our lab report, all right? So we call that a differential count. So we're going to see if we have the normal amount of white blood cells, or if they're elevated, or if they're decreased, okay? So when we talk about leukopenia, has anyone here ever heard of the term osteopenia? All right, we've heard of osteoporosis, I think everybody here. That's when you have really low bone density to the point where you are susceptible to pathological fractures, all right? So osteopenia, all right, is when you have decreased bone density, but it's not too bad yet where we're really concerned about you. So penia is a reduction in, okay? So leukopenia is a reduction in the number of leukocytes. So if you have decreased white blood cells, you're putting yourself at a pretty significant risk, all right, of getting infections, all right? Back in the day, you don't have to worry about it too much now. When I was growing up as a kid, you used to hear the term bubble boy or bubble girl. And these are people that didn't really have an immune system, all right? There's a lot of other issues regarding that. They literally had to be in a bubble, like in their room, all right, walled off, all right, because they were at high risk for infection. So think of these people, all right, not to that degree, but they are at a risk, all right? If you have low white blood cells or low leukocyte count, you are putting yourself at risk for infection. All right, now we swing in the other direction, leukocytosis. That's when we have an elevated leukocyte count. All right, if you see that, you're looking at a lab, you're like, oh, all right, leukocytosis, the white blood cell count is considerably high. What's happening here? Well, what's the purpose of white blood cells? fight off infection. Okay, so these people probably have some sort of infection, but we can't rule out stress. Okay, cortisol levels will cause that to occur, right? Because that's the stress hormone. Okay, so think two things: stress and infection. Okay, all right. So the differential count. This is when we're going to look at all the different types of white blood cells. All right, and we're going to see, all right, is it elevated or is it decreased in the number of white blood cells? But also, we're going to look to see if any of those cells are immature. Okay, because that will tell us a couple things too. All right, when you start to see immature white blood cells, your first thought should be what's going on in the bone marrow, what's happening, or what's going on in the thymus gland, right? Because that's where some of them go to mature. Okay, but I'm thinking bone marrow right away. What's happening there? Why am I getting so many immature white blood cells? Okay, so now when we break down the different types of white blood cells, we're going to apply some of these similar names. All right, neutrophilia is an increase in the neutrophils. So what did we say? Neutrophils like to go after bacteria. So the first thing I'm thinking is bacterial infection. Boom, right away. Okay, so of course I'm going to think stress too, but also tissue necrosis. Okay, because remember what I said, one of the first leukocytes on site for damaged tissue, you cut yourself or whatever, are going to be neutrophils and macrophages. Okay, so if you're seeing increased neutrophils, you should be thinking this person's not running a fever or anything, but you might see that they have a big gash somewhere. Okay. That hasn't healed over all the way. So they're going to have tissue necrosis going on. All right, this term here, left shifted differential, all right, this is just telling me, all right, when I see that in my report, I'm thinking immature neutrophils, okay? They're coming into circulation from where? Bone marrow. So again, I'm going to start looking, okay, what's going on here? I'm thinking bone marrow. I'm going to do a couple other things. It's between normal and osteoporosis. Oh, yes, sorry. Yes, Lucy, it is. Normal, if you're, I didn't see that. That's for osteopenia, is that what you're saying? If you're going to put bone density on a scale, yep. Normal, osteopenia, osteoporosis. You'll be osteopenic before you get osteoporotic, all right? You might not spend a lot of time there, but you will be. All right. So that's what I would do, and then when I'm seeing that left shift going on, then the next thing I would do, I would do a bone scan, okay, and see if there is increased activity in the bone marrow cavity, and then possibly, if I had to, take a bone marrow biopsy. All right, neutropenia, again, anytime we see penia, we're thinking decrease. So this one here, we see decreased neutrophil, all right, count. All right, anemia, okay, we don't have the proper ingredients to make, all right, our leukocytes or our neutrophils, all right, so we're going to see decreased numbers there, all right, all the time. Drug and radiation therapies, that's a huge side effect for people that undergo chemotherapy and radiation therapy for cancers, all right, because if you're not quite sure like what chemotherapy, at least way back in the day when they really first started using chemotherapies on people, it was to arrest or stop all dividing cells, because that's what cancer loves to grow. So cancer is an abnormal, unregulated cell growth. So it's constantly dividing. So what do? Well, we can't. Well, back then, we couldn't really just pick out cancer and leave all the other cells because we didn't have the technology for that. We're a little bit better now because we have cell markers and that kind of thing. So we were just like, you know what? Get it. We're just going to kill all the cells that are rapidly dividing and stop that. And that's what they would do. Well, guess what? Bone marrow is constantly making your blood-formed elements. White blood cells, red blood cells, all right, the megakaryocytes. So that suffers. So bam, when he hits you with the radiation and the chemotherapy, that's going to scrap the reproductive ability of your red bone marrow to make those. Now we're better. We have some better drugs. It's all about drugs. Okay. My niece had leukemia when she was 4, and she had, you have to forgive me, I think it was ALL, the acute. The doctor said she had if you had to have leukemia, that's the one you wanted. Okay. So she had I believe it was the acute lymphoblastic leukemia, and they gave her this drug called vinblastine. No. Yeah, vinblastine. And vinblastine, when they had to do the chemotherapy on her, the tech would come out and hang the bag with these thick rubber gloves. I'm not talking about rubber gloves that you use to do the dishes. I'm talking about thick rubber gloves. They're like 30 layers of that if you were to take all those dish gloves and put them on. And the guy said, because my sister's like, what? Why do you have to use those rubber gloves, to hang that? He goes, this stuff will take the paint off the car. And they're pumping that into her body. That's how crazy that stuff was. It'll mess you up. It'll mess up the nerves. All right, anyways. So when we talk about monocytes, all right, same type of situation. When we change our monocytes, so if we have an increase in monocyte, you want to think of chronic inflammation going on. You'll get inflammation because you have to understand, inflammation is part of the healing process. It's natural. It's just when there's too much of it going on. All right. So if we're dealing with chronic inflammation, because remember, when tissue is damaged, all right, the first two cell types, or the two early cell types on hand, are going to be macrophages and neutrophils. So we'll have chronic inflammatory issues and tuberculosis, because what will happen in tuberculosis is you'll get these areas in the lungs. The macrophages will go to where the tuberculosis pathogen is, and what it does is it phagocytizes the pathogens. But as it's doing it, your body walls off the area around these macrophages, and it essentially makes these kind of, I don't want to say balls, but you get these tubercles, okay? And the virus, I shouldn't say virus, excuse me, it's not a virus. The pathogen is inside there, and it goes dormant. So you could be fine, unless you're taking drugs, and then you can actually get rid of it. But point being is, all right, we'll see these monocytes, all right, in those areas of tuberculosis infections. So when we see a decreased number, okay, think prolonged steroid use, prednisone, okay? When we talked about it before, back in chapter 17, when we were talking about cortisol and corticosteroids and whatnot, one of the things that they do is decrease your immune response. Okay, so long-term steroid use, I'm not talking about anabolic steroids, I'm talking about catabolic steroids, all right, will decrease your immune system, okay? All right, basophils, these guys here, all right, we're going to see, all right, when we're having an issue, if there's an increase, all right, we're going to see, think bone marrow issues. When we have a decrease, again, allergies, okay? Allergies, stressors. Shut this off. Okay, lymphocytes, remember what I said, lymphocytes, think viruses, okay? Now, it's not the only thing they fight, but think viruses right now. But they'll also, like neutrophils, be seen in chronic bacterial infections, okay? And then with the type of leukemia that my niece had, this is where we saw she had increased immature lymphocytes. She had the ALL, all right, and also multiple myeloma. Does anyone know what multiple myeloma is? It's another bone marrow type of pathology. Okay, it can affect the bone marrow quite a bit, and the plasma cells. Because remember, our plasma cells, you actually see an elevated number of B lymphocytes and plasma cells in multiple myeloma. All right, so when we see a decrease in our lymphocytes, well, way back in the 80s, 90s, when there was a lot of talk about HIV/AIDS, okay, because it affects the T helper cells, the CD4 cells, and we'll talk about that more in detail when we get to immunology. All right, also some of our leukemias, sepsis, all right, infection, okay. And then again, like I said, with eosinophils, when we see increased numbers of those, all right, allergies, parasite infections. Those are the top two things that you should be thinking of right away. All right. Now, again, if they haven't really gone outside the country or been doing it, if they've been bound, not bound, but wheelchair bound or nursing home bound older patient, and they're not getting out, so the likelihood of them coming across any parasitic worm-like infections is is reduced. All right, highly unlikely. All right, questions so far? All right, and then the last part here, speaking of leukemias, let's talk about those for a brief minute here, okay? So when we're talking about leukemias, all right, a lot of the times we're going to deal with, all right, where these cells originate, so in our bone marrow here, okay? So this is some sort of cancerous issue going on here, all right? And during the process of the formation of these types of cells, all right, we're going to see, and in some cases in the beginning, we're going to see a huge spike and a huge increase in our leukocytes, but they'll either be immature, all right, or they will have some sort of abnormality associated with it. But your bone marrow is just spitting out all these leukocytes. So it doesn't have time to spit out, all right, red blood cells and platelets. So these people, okay, now here's the crazy part. So if you're putting out poorly formed or abnormal leukocytes, how do you think your immune response is going to be? Crap. It's going to be garbage, okay? Because you don't really have anything to fight. So you'll have the patient have all sorts of unexplained fevers. Doesn't make sense. I don't understand why they're getting sick all the time. They're having fevers. They're anemic because their red blood cells, all right, are in low amounts. So their oxygen carrying capacity is garbage, all right? And they can't clot very well because of our megakaryocytes aren't producing platelets. Okay, so they'll have a vast array of different symptoms here, okay? So when we're dealing with the acute leukemia, again, the acute ones are the ones that you want to have, if you have to have one, all right? So they occur pretty quickly, okay? You'll see them more commonly in the younger age groups. So you'll see AML, ALL in young kids, like my niece, and then the CLL and the CML in older patients. And that's the chronic leukemias, all right? Slower progression, they take longer. All right, we'll see these in the older individuals, okay? I've never seen a kid want to go to the hospital more than when my niece was getting her chemotherapy. She would pretend to be sick. This is how good of a children's hospital this hospital was. It was up in New York called Strong Memorial Hospital. And I'll never forget, it was Thanksgiving Day. And man, this was close to 20 years ago. And so I remember I was going to come over and visit my sister and her family, and they were in a rush. Her husband and her were like, listen, can you watch our son? And he was just an infant. We've got to run. Katie is not feeling well, blah, blah, blah. They spent 6-8 hours there, only to find out that she was fine, but she just was bored and wanted to go and be at the hospital. I'm like, oh man. But I mean, when you're a kid with cancer, you can get away with murder. You're not literally, but you know what I mean. All right, let's talk about the last type of blood-formed element in our circulation here, okay? The platelets, okay? So the platelets, these guys, all right, their main job is blood clotting, okay? So this is another type of cell, all right? And I even hate to call it a cell because it's not really technically a cell. All right, we talked about the formation of the platelet, all right, how you get this megakaryocyte that'll just migrate close to a capillary and it'll shoot out these processes. Hold on, I'm going to find the picture here. I don't want to insult you guys and just draw those horrible pictures, but as you're writing down, I'm almost positive. There it is. Bam. All right, so here's what we're seeing, okay? You can see we get this big, huge megakaryocyte, all right? It migrates close to a capillary here, and it sticks its long processes in between, all right, the endothelial cells here, and then just as the blood is going by, it just tears off small pieces of it. All right. So technically, platelets aren't cells; they're just cell fragments. Right. So they're not going to have a nucleus. They're not going to have any organelles. They're just parts of this huge, massive cell that just kind of just gives parts of itself up into your blood flow there. Okay. So I have to make sure that I don't call it. I so want to call it. Where are we? Bam, there we go. All right. A cell, but it's not. Okay. So there's no nucleus whatsoever, but they are derived from these megakaryocytes. Okay. So they don't last very long. And in fact, aspirin, all right, well, and that's one of the reasons why anybody with heart disease that has a history of just heart failure, myocardial infarction, stents, blood clotting, anything like that, at risk for stroke, most doctors will say, listen, you need to take a baby aspirin. All right, 81 milligrams a day. And what that does is that helps to prevent the clotting, not all, but helps prevent the clotting from platelets. Okay? It helps to block what's called thromboxane. Remember when we learned about the eicosanoids, the locally acting hormones? We had prostaglandins, prostacyclins, leukotrienes, all right, and thromboxanes. That's one of the types of eicosanoids. All right? So this helps to block thromboxane, one of those eicosanoids, which helps with clotting, all right? And so it takes anywhere from 6 to 10 days to recycle that for the platelets, which is pretty much the same amount of time for these platelets to circulate through the blood, okay? So keep in mind, all right, those time frames are very similar. That's why they recommend baby aspirins, right, to these people, so that it helps to block the clotting ability of platelets. Okay, so as you can see here, all right, when we talk about the purpose of platelets is to stop bleeding, so we call that hemostasis, okay, and there's 3 stages to that, all right. So the first stage is when, and you can see here in the example, we're cutting ourselves with something sharp, like a knife, let's say, when you're cutting limes for your margaritas or your Coronas, all right. So you cut into the blood vessel here, right, and immediately the blood vessel will go into vasoconstriction. Only makes sense, right? You want to reduce the amount of blood flow to the area because it's compromised. So the first thing that happens when we talk about the stage 1 here is they call it vascular spasm, but basically that causes vasoconstriction. So the diameter, all right, of this blood vessel decreases. When it decreases, less blood can go into that area. Okay, that's the first part. So all this damaged tissue now in this area is giving off chemicals. We'll talk about some of those chemicals, but it's giving off chemicals. Remember we talked about that term chemotaxis? So now that chemotaxis, all these chemicals are going out into the circulation, and it's telling, all right, these platelets and other things, all right, not red blood cells, your neutrophils and other leukocytes to migrate to this area, because we got to stop the bleeding. So the platelets start to aggregate towards that area and start to clog things up, okay? White blood cells will come over there to help clean it up. Red blood cells will get stuck into it. We'll go through all this, all right? So then we start to clot the blood so we can stop the bleeding. And when that occurs then our blood vessel, all right, will start to kind of relax a little bit and go into vasodilation so we can resume that normal blood flow. All right, we're going to break it down. Let's talk about the first one here, the vascular spasm. All right, the first part of what happens during hemostasis. Okay, so again, we decrease the diameter, that decreases the amount of blood flow, which decreases the amount of blood that we lose through leakage in that area there. Okay, because we haven't clotted it yet. Okay, so this takes a couple minutes. So the endothelial cells are going to release, all right, through that process of chemotaxis, all right, chemicals that are going to signal to, all right, our blood clotting platelets, and to also, all right, our white blood cells to head to that area there. Okay, so the first part, spasm, which causes vessel constriction. All right, this is almost like a positive feedback type of system, because as these endothelial cells release chemicals, they're going to continue to further constriction. It's a positive feedback reaction, okay? Until we can stop the blood flow in that area. Questions about that before I move on to the next one? Pretty simple so far, right? Good, we gotta keep it simple. All right. So before we go much further, you have to understand, have any of you ever wondered, I mean, just from going over this, kind of like, hey, you know what? How come platelets don't normally just stick onto things? You know, you would figure that that's their job, right? To clot blood. All right, so when things are hunky-dory and blood circulating through, all right, why don't platelets stick onto our blood vessel walls? Well, there's a reason for that, okay? And it's because your blood vessel walls, your endothelium, those simple squamous cells, all right, release this prostacyclin, okay? Again, that prostacyclin is one of those eicosanoids, which are those locally acting hormones that get, does anyone remember where eicosanoids come from? Talked about it in chapter 2, but we also talked about it a little bit in chapter 17 this semester. You want to commit this part to memory. Eicosanoids come from your plasma membrane. All right, one of the phospholipids there, all right, has an amino acid called arachidonic acid. That's where these eicosanoids come from. Okay, so arachidonic acid undergoes a series of what they call enzymatic cascades, all right, which are these chemical reactions, and along those series of chemical reactions, it will yield us out these prostacyclins, these prostaglandins, leukotrienes, thromboxanes. Those are the eicosanoids. Those are the locally acting hormones. Anyways, so in a normal blood vessel, all right, these cells will coat their walls with this prostacyclin. And that prostacyclin prevents, all right, the platelets from sticking to it, all right? And it does so through this, all right, cyclic AMP, okay? So they make this cyclic AMP, and we saw the cyclic AMP in chapter 17 when we were talking about secondary messengers, okay? Briefly talked about that when we were talking about adenylate cyclase and whatnot. So again, cyclic AMP is present in cells also, all right? So it produces, all right, the cyclic AMP production. And because of that, all right, we cannot activate our platelets, which is good. We don't want them activated in a normal circulation. All right, when things are good, fine. We want our platelets inactivated. Okay, so these healthy endothelial cells will keep producing this prostacyclin, all right, which will then help these platelets to produce that cyclic AMP, which inhibits their activation. Okay, so going back now to our damaged blood vessel. Damaged blood vessel has occurred. Okay, our chemotaxis is occurring. Okay, and so our damaged tissues, all right, are sending out those chemicals. Collagen fibers, remember, all right, collagen is found in large amounts in connective tissue. Okay, well, that connective tissue is going to surround our blood vessels here. So those collagen fibers, all right, are going to help release this substance here, von Willebrand factor. All right, it's part of the clotting process. All right, so they help to produce that. All right, and that allows the platelets to stick to the collagen. It's like a net. Think of the collagen as like a net. Okay, and it's catching. Or like if you're floating down a river on a tube and somebody sticks their hand out, all right, to grab onto you. All right, that's what we're seeing here. Okay, so the collagen produces the von Willebrand factor, and it allows the platelets to stick. Okay, and so the platelets stick onto there, and as more and more kind of not aggravate, but accumulate in the area, then we start to slow the blood flow down through that wound, okay? And so we're going to start to get more junk to accumulate in there. I hate to say junk, but stuff to clog it up. It's like, when you clean the sink drain out, it's not, well, sometimes it's just one thing, right? But it could be hair in there, it could be food particles, it could be all sorts of stuff in there. So that's what we're going to see here, all right, when we talk about our platelet plug formation occurring. All right, platelets are going to aggregate, towards that area and kind of plug things up. Red blood cells will start to get in there. All right, jumping into this part here, okay, going into a little bit more detail. So now we've activated our platelets, okay? And so when this occurs, you need to know these, okay? Our platelets are going to release serotonin. We've seen that before, right, as a neurotransmitter, but serotonin has lots of other properties involved. And thromboxane A2, that's another eicosanoid, okay? These two chemicals, again, positive feedback, are going to prolong our vascular spasms, that vasoconstriction, okay? Well, now our ADP and thromboxane A2, all right, those chemicals are going to cause more platelets to accumulate and move towards that area there. And then those platelets, all right, will degranulate with their chemicals, serotonin, thromboxane A, and so this cycle keeps repeating and keeps repeating through that positive feedback, okay? So as these platelets kind of gather there, all right, as we start to clog things up, then we're going to move to the next phase of tissue healing. We'll get into this in more detail in trying to remember which chapter that's in. Might be chapter 20, okay? We'll get into it in much more detail. I just want you for right now, just know these three players: serotonin, thromboxane A2, and then ADP, okay? So we'll get these chemicals, which will then stimulate more clogging or coagulation there. And then these same chemicals will also trigger the cells that are existing there, like fibroblasts, right, to actually undergo cell mitosis, right? So they'll start to divide, all right, as they're repairing that tissue there, okay? We'll go into this much more detail. So if you're ever reading a lab report, okay, CBC with diff, and it comes back and they diagnose the person with thrombocytopenia, again, penia is reduction of some sort. Thrombocytes are what we call platelets. All right, we're talking about a low platelet count. Usually you'll know because it'll say some of the signs and symptoms that this patient's been exhibiting is difficulty clotting. They'll have what they call petechial hemorrhages, these small little red dots over their shins and on certain parts of their body, okay? So we'll see that overall they're having a problem, right? They'll come in saying that it takes them forever. They'll get a nosebleed and it just keeps bleeding, all right? There's other things that can cause that, but for a minor nosebleed, all right, that should stop within a minute. Okay, that's usually about how long it takes for the blood to clot, okay? So if we're having a situation in which it's taking longer than that, like up to 10 minutes or 15 minutes, all right, they could have a clotting issue. They could have thrombocytopenia, or they could have an excessively high blood pressure, which is pushing too hard and not allowing the blood to clot. There's several different reasons, all right? So if we go back to this picture here, okay, you notice that the blood, all right, is only clotting around the area of the wound. It's not clotting over here. It's not clotting over here, because these endothelial cells are still healthy cells. They're undamaged. So they're still producing that prostacyclin, all right, and which is going to repel the blood platelets from clinging onto the wall. Okay, here it's damaged, all right, so they're not producing the prostacyclin, so the platelets will migrate to that area, okay? where there's damaged collagen and other things also, okay? But over here and over here, all right, those areas are still producing, okay, the prostacyclin, so your platelets will not stick onto them, okay? So here's a picture. I love this picture. All right, you can see here in our electron microscope, this is what it looks like. All right, so I compare it to like throwing a net down and catching fish or catching whatever. And so you can see all these platelets here, okay, are sticking into this net. But what makes up this net here, all right, is one of our famous proteins that the liver makes, all right, fibrin, all right? The liver makes fibrinogen. It's one of the plasma proteins that we look at. And fibrinogen goes through a series of, again, enzymatic reactions. And the end, we finish off with fibrin, okay? And it creates this kind of net here that catches platelets and catches our red blood cells, okay? And it traps all this stuff, and it makes our clot, okay? Yes, ma'am.
I got a little confused. Can you explain how the platelet activation is inhibited and then not activated again?
Okay. So platelet activation is inhibited. Okay. It's inhibited because in a normal scenario where there's no damage whatsoever, okay, the endothelial cells, the blood vessel cells, make prostacyclin. So it keeps the inner lining of our blood vessels nice and smooth, and it literally will repel platelets, okay? And so the platelets will just bounce around, hopefully not too much, and just flow down the blood vessel there, okay? So this prostacyclin here, think of it just repelling the platelets, okay? Basically how it does that though, all right, how it does that is that it causes the platelets to make cyclic AMP, okay? And the production of that cyclic AMP prevents the platelet from activating itself, okay? Or you could say it inhibits the platelet from activation, okay? So that prostacyclin causes the platelets, all right, to produce cyclic AMP.
So then when it gets damaged,
So what will happen is when the endothelial cells get damaged, they're no longer making that prostacyclin. So that prostacyclin is no longer causing the platelets to make the cyclic AMP. And when those platelets are no longer making the cyclic AMP, all right, they can now activate themselves. Okay? So then when they activate themselves, they go here. There's granules inside the platelets, and they'll release serotonin and thromboxane A2. Okay? So those will help to continue and prolong the vasoconstriction or the vascular spasms. Okay? Now, the thromboxane A2, in addition to ADP, we know what ADP is. All right, we have ATP, we take a phosphate off of it, it becomes ADP. Okay? So ADP and that thromboxane A2 will now attract, all right, and cause more platelets to come to that area. And then that promotes those platelets to also degranulate and release more of this. And if we're releasing more thromboxane A2, all right, that is going to then attract more platelets. So we see we're in that cycle now, that positive feedback situation, okay? And all of that is going to help to stimulate coagulation, blood clotting, okay? So once we clot the blood, then we've blocked off that area, and then we'll get into more chemical involvement later on in another chapter, all right, and what we'll talk about. But just for right now, I want you to know those three things, all right? Serotonin and thromboxane A are going to be stored in the platelets granules there, okay? And they'll get released, all right? And in addition to the ADP, all right, we'll see vascular spasms and the attraction of more platelets to the area, okay? All right. So again, remember back in Bio 210 when you were talking about with your instructor the purposes and the value of calcium. Okay, and we learned that calcium, all right, not only was important when we want to have strong teeth and bones, it's also important when we want to have, all right, the appropriate neurological function of a neuron, okay, because we need calcium to release our neurotransmitters, right? We also need calcium, okay, for blood clotting, okay? Well, obviously we need it for, leaving out a very important part, calcium is important for muscle contractions too, but we don't talk about that in Bio 210 when we talk about blood clotting. So now we're going to talk about its importance in blood clotting. So for clotting to occur, all right, we need the proper ingredients. The first one is calcium, listed here, because calcium, all right, I'm going to come right back to this slide. See this right here? It's in your book. I don't expect you to memorize it, so don't worry about it. All right. But this is what we call the coagulation pathway. You have a pathway inside blood vessels and a pathway outside the blood vessels. But if you look, oh, it's tough to see. If you look along here, all right, basically what this is it's just a series of steps of chemical reactions. You start with one, what we call a substrate. It undergoes a chemical reaction, and then it turns into a different type of substrate. Most of the time, you're going to see we have an inactive form of something. All right, we have an enzyme that activates it. Okay, and then we'll have another activation. Point being is you need certain things for this to occur. Okay, calcium is one of those things. Okay, vitamin K is another. But if you look here, I just want you to get the appreciation. Calcium is found at different parts of this whole process. Okay, and all of this, all right, comes down to forming fibrin. Okay, the net that we're going to use to help clot that damaged blood vessel. If you want to take the time and learn all this, I'm not requiring you to do it. I had to learn a long time ago and I hated it. But my point being is, all right, I want you to understand that you're going to see several steps that occur. All right, and it's all going to come down to what we call the common pathway. But essentially, all we're doing is we're taking enzymes. They're going to be activating certain proteins that are all going to eventually come down to creating our fibrin. Okay, and it's our fibrin that creates that net. So platelets can help with the clotting process. And let me go back. Okay, so that being said, when we have our clotting going on, so you need to have, now I want to say high calcium levels, but ample calcium levels. Someone that's hypocalcemic could potentially have clotting issues. Okay, the clotting factors were all those different things that I just showed you on that other page. Factor 12, factor 1, factor 2. All right, we just called them factor 1 and factor 2 because when we discovered them at the time, I guess people weren't really creative enough where they decided I'm just going to call it factor 1, factor 2, and then we started calling them different things later on. All right, but those names still stuck. All right, so we need our clotting factor. We definitely need our platelets. All right, because they're going to help with the clotting, and then finally vitamin K. Okay, so understand that clotting factors are basically enzymes. Okay, they will be inactive, not all of them. All right, but they're enzymes. Enzymes facilitate chemical reactions. Okay, but an important thing. This is why it's so important. You know that you take. Well, I'm not doing a PSA. All right, but you take good care of your liver because your liver makes a lot of these clotting factors. That's why people with liver disease will have, all right, in some cases, depending on how bad the liver disease is, have an inability to clot. They bruise easily. Okay, we see that. Okay, so the clotting factors we need. Vitamin K, all right, again, is going to help with making some of these clotting factors. All right, 2, 7, 9, and 10. All right. And then some of these factors that we see, if you follow the enzyme pathway here, are going to activate some of the inactive forms. That's what we're talking about here. Right? They're proteases, and a protease is going to be an enzyme, a protein enzyme, that's basically going to take an inactive clotting factor and then activate it. All all right? And then that allows that cascade, all right, that flow chart here. So when we go from activating this, all right, clotting factor, now this clotting factor can go and activate this inactive clotting factor. So it just kind of runs down like dominoes falling down. As long as we have all the proper ingredients, we can come all the way down here and get a clot. If you are missing certain enzymes along the way, if you're missing calcium along the way, then you're going to have a hard time clotting. Okay? Again, I don't want you to have to worry about all the specifics there. That's a lot. Questions so far? Almost done, guys. There's no guys in here. Ladies, apologize. It's a New York thing. I really worked hard on trying to get over that. Okay. Last slide right here. Here we go. So, when you damage yourself, if you are bleeding, okay, your body springs into action. Now, if it's a small paper cut, no big whoop. We just talked about what happens with that. Okay, you undergo vasospasm. All right, you start to form a platelet clot, and then you stop the bleeding. Okay, but what happens if you cut something a little bit bigger, like an artery? Okay, like an artery in your wrist or whatnot, or in your leg. Okay, car accident or whatnot. If the amount of blood that you lose, all right, gets close to 10% of your overall blood volume, then we're going to jump into action with our sympathetic nervous system, our fight or flight. Okay, so the sympathetic nervous system gets involved. Okay, and the first thing it does is, on a large scale, increases vasoconstriction. That makes sense, right? We're going to vasoconstrict. We're going to make the blood vessels smaller. So we want less blood to flow through that damaged blood vessel. Okay? What else are we going to do? We're going to increase our heart rate. All right? We're going to increase the heart rate because if we're losing blood, we still have to maintain our heart rate to pump the blood to the rest of your body. Guess what? Your brain still needs blood. Even though you cut an artery in your leg, your brain still needs its blood. It needs its glucose. It is a sugar fiend. Okay? So we're going to increase our heart rate. And not only that, we're going to increase how hard the heart is going to contract. So not just how fast, but how hard. We're going to make it more forceful. We can get more blood in there, okay, and speed it up. We can get more blood out. Okay? So this gets our blood to our heart, which is our pumping mechanism, but most importantly to our brain. Okay? So this is good for a while, but if you start to lose over 40%, all right, then you start to have some issues. You go into shock, a couple of things will happen, all right? But if it's not taken care of, all right, at that point, then you got a lot more issues on your to deal with. That's why it's very hard for me to watch some of these movies in which someone gets shot or stabbed and they lost a lot of blood, and they're still doing all these amazing things, you know, like for an hour afterwards. You ever wonder, like, you watch these TV shows or movies? Well, maybe not, but you will now, because you're gonna be like, that's not realistic. You know, that guy lost, you know, they'll say, oh, he's lost 1 liter of blood. Well, last I checked, that's 20% of your blood, all right, for a male, all right, because you have 5 liters for males, all right. So, I mean, the fact that that person is still doing what they're doing. So, you know what they say? It's called suspension of disbelief. When you watch movies, you have to just like, okay, I'm going to sit there and just be mindlessly entertained, which is okay. All right, any questions on that? That was the last slide. Woo, I didn't think I was going to get that done in the lecture. So this is all the material that you are responsible for the lecture exam that is tomorrow, I believe, right? Yeah, tomorrow, okay? So it's on chapter 17 and 18, okay? It's going to be 80 questions, I believe, okay? I know. But so I believe it is. It's either 75 or 80. Now you have me doubting myself. Great. Now I can't. But anyways, so make sure you only have 1 day to take it in, okay? So starting tomorrow, you have to submit it by 11:59 p.m. by tomorrow night. All right.
What's the time?
The time on it is, I want to say it's a minute. It says it tells you what the timer is, but I'm almost positive it's a minute per question. We're a little bit more lenient this semester. I don't know why. I don't know. I mean, don't get me wrong. I mean, I'm sure people appreciate that. Okay, so let's do this. Let's take a break. Sign in on the piece of paper over there. Let's take a 15-minute break, and I will see everybody back here a little after 7:30, and we'll finish up the heart in lab, hopefully. All right, peace.